1 second. Video on. Okay. See, what I do is put code on the web page. Embed code. Do you guys know what that is? Embed code?
That's actually on a pre-planned live stream is where you have to share a web code. I believe it says YouTube, so it should already be live. I don't think you need to put on it the web code. Let me check.
Hey, hold on. Hey, come on.
Yes, sir, it's live. I believe it says
Yeah,
YouTube.
it's live. It's live.
Should already be live.
Okay, let me just start now. I edit that first part out. Okay, that most people are watching on YouTube. We don't even know they're there. Okay, here we go. We're all live. 10, 9, 8, 7, 6, 5, 4, 3, 2. Good morning. This is Dr. John Bennett broadcasting from Miami Beach, home of Neurosurgical TV. We have the honor of having more or less the beginning. Rohan did a talk last week. This week, Yash Pal is going to do a webcast for India Neuro Medical Student Group, which we hope will grow. And we'll have different webcasts. We have a basic webcast now. Hopefully, we will be adding more to make it useful for you guys to spend some time. And I have Rohan Main. I'll let him be the host here to introduce the speaker. Welcome, Rohan. It's all yours.
Greetings everyone. Myself is Rohan Mane. I'm a sixth year medical student. I'm happy to invite and host Dr. Yashpal for this session. He will be explaining about the understanding of disc herniation and its anatomical and physiological perspective. So the floor is yours, Dr. Yash.
Thank you so much for that lovely introduction, Rohan. And first of all, I'd like to say a very good morning to every one of you. And it's truly a pleasure to be here with all of you. And those who are watching it live on YouTube too, a very good morning, a very good day. So with your permission, Dr. John, I'd like to begin my presentation.
So, Dr. John.
Yeah, perfect.
Yes.
Right. So my topic for the presentation today is going to be discuss hernia, where we're going to be talking about what happens to a normal disc and how it gets herniated. So over here, you can see to your right side that what a typical anatomy of a disc looks like. Disc, in particular, what I'm talking about is going to be the intervertebral disc that's present between the disc of the spine. So this is what an intervertebral disc looks like. And you can see that little red spot over here. That red spot is what the herniation is. Why does it look like that on the outside? Because that's what it looks like right when you dissect it in the middle. So think of it as two knuckles, okay? Here are my two knuckles. These two knuckles are actually what the vertebral columns looks like. And the intervertebral disc is going to be right in the middle. So what happens is the bulging occurs and the part of herniated disc, or rather the nature of it or the layers of it, comes out and oozes out because of weaker walls and because of certain things, which we will be exploring in further slides. Okay, so right here you can see this is normal anatomy, normal vertebra, normal everything. This is what diagram looks like, completely normal over here. And this is what a herniated one looks like. Typically, this is what the presentation is of the herniated disc. Next, we will be talking about on a bit microscopic level of it. Like I told you, we are going to be having certain layers of it, which will be weakened up. Like there are two layers in a disc, which is one of them is nucleus pulposus, and which is the middlemost layer, and the outermost layer is going to be annulus fibrosus. Nucleus pulposus, as you can see on the top, it's right in the middle, and we're looking from the side layer, and we're going to be talking about the layers that it mentioned. So allow me to shift a little so you can have a look. Yes. Annulus fibrosus layers, creating an angle ply structure formed of distinct lamellae made from collagen fibers, angled obliquely, and the oblique angle alternates each in adjoining layer. So it's all like layers of an onion is what it looks like depicting from the top, but in reality, it's just a bunch of collagen having different thickness placed against each other. Then, when you put this particular disc into a vertebral column, this is what it looks like. So you can see there are certain thing, or rather a dark line over here, you can see. It's called end plate. What does an end plate do? It keeps the bulge of nucleus pulposus in place. What happens in end plate when there is a kind of disorder, like a disc herniation? What happens to it is there can be a biomechanical disaster in this sense, because of which you can understand truly the nature of how it affects. So this is what the normal anatomy looks like by Dr. Frank Netter. I'm aware if you are a junior medical student, then Frank Netter's Atlas of Anatomy is where this diagram is from. He has made it very beautifully for us, and you can see how the disc actually looks like. In reality, also, it has a slightly bluish color, and that's exactly what has been depicted here. And right on the top is what you can see, an individual piece of intervertebral disc. And right over here, this is the vertebral column on top of which the disc is placed. Now, let me go back one slide and talk about what it is in terms of the biomechanical masterpiece, right? So I mentioned annulus fibrosus, I mentioned nucleus pulposus, and I mentioned end plates. Let's talk about what it means in depth. So annulus fibrosus is concentric laminae of type 1 collagen. Crucial point is alternating oblique fiber orientation. It is vital for resisting multidirectional force, which is compressive and torsional. So the crux of having a vertebral disc in a human body, or in evolutionary way, I would say, is that it was present for support. Support in the sense of movement, support in the sense of force applied externally, and support in the sense of natural stimuli. So support in the sense of force is what we are talking about in particular way of compressive and torsional. When your body turns left to right or front to back, there is a torsional force there. And when you lift weights, or rather if your body is doing certain work in places where you're using your arms and legs to lift certain things, the disc actually gets compressed. So that's also a crucial point. Then there has to be a differentiation done between the outer 1/3 and the inner 2/3. So the outer 1/3 is innervated by sinovertebral nerve, which is a vascularized part, and then there's inner 2/3, which is aneural and avascular. There's no nerve endings, no kind of involvement or vascularity also there. No innervations, no vascularity. So only the outer part, which is sinovertebral nerve, is there as the innervations. Then we'll talk about strong attachments. Vertebral end plates like Sharpie's fibers. Then you've got anterior longitudinal ligament and posterior longitudinal ligament. And this is for the annulus fibrosus, which is the outer layer. Let me show you. Right? You can see annulus fibrosus. Then nucleus pulposus comes in. Nucleus pulposus composes of something called a gelatinous core. Gelatinous core over here, as you can see in this particular part, is type 2 collagen. It is rich in proteoglycans, particularly known as aggrecan, and its function is to act as a hydrostatic ball bearing, distributing compressive loads evenly, facilitating movement, and its turgor is essential. Turgor is like the hydrostatic phenomena, which we can see particularly in nucleus pulposus. Then we have got vertebral end plate. Vertebral end plate, like I told you, are going to be layers which are critical for nutrient diffusion, and they tend to have a certain structural advantage towards the nucleus pulposus too. So there is something called bone end plates, which is subchondral bone of vertebral body. What happens in these bone end plates is there is an attachment site, and you can see that there is also a transfer, metabolic transfer in particular. This one in particular is going towards the annulus fibrosus and not the nucleus pulposus. Over here to this side, the long diagram you can see is going towards the nucleus pulposus. Now that being said, allow me to continue. And talk about the vulnerability. Okay. So vulnerability is in particular for vertebral end plates, where it is the site for small nodules, which is herniation into the vertebral body and which indicates end plate weakness. This can particularly lead to having symptoms or clinical presentations as pain. It can be discomfort. There can be unsteady gait while walking. Okay. Now let me talk about what the disc actually has in its physiology, in particular about the nutrition and biomechanics. So nutrition is, again, it's largely avascular in adult disc. Then what happens, like how can we rely on nutrition if it is avascular? We rely on the phenomenon of diffusion, where there is glucose oxygen transferred into and waste removal is done of lactate, which is primarily done by diffusion in the vertebral body through the cartilaginous end plates, like we mentioned earlier. Then there is hydration imbibition. High proteoglycan of nucleus pulposus content allows to imbibe water. Okay, and because of this turgor phenomena that you can see is fundamental for the load bearing capacity of the entire vertebral disc. Then there's also diurnal variations, which means, or it indirectly translates to how during the day the different physiology of disc changes. So when it's like a common phenomena that is often told in amongst like children, where if you wake up, you're taller than when you're going to sleep. The actual anatomical reason behind that is the size of your disc is changing when you're sleeping. There's also an effect of gravity, which causes the fluid influx, and it keeps it in place till the time you wake up. Then when you stand up, you're standing against the gravity, so the fluid loss happens and the disc reduces. Then we'll talk about this diagram I already mentioned. We're going to talk about how the degenerative cascade occurs. So in this particular part, I would like you to focus on fissure stairs very closely, because this is what is very essential for us, and it actually affects how it all occurs in terms of disorder, or like how diseases can occur because of this. So what happens is there is disc desiccation, which is a decrease and reduce in water binding capacity. Then there is changes in collagen types, which is increased type 1 in nucleus can occur, and can also occur in terms of decreasing. That being said, let's move on to the fissures or tears. Crucial precursors. Explain types: radial tears, concentric tears, rim lesions, and these are what some of them exist as, to name a few. These are often due to repetitive biomechanical stress, aging, or loss of nuclear support. Like I said, end plate, cartilage decreasing can also cause certain kind of fissure or tears. Then there is loss of disc height. Disc tends to be of certain height, and that indirect consequence of desiccation and collapse can lead to increased load on facet joints, which can contribute to facet arthropathy, decreased volume of intervertebral foramen. Now, here are some kinds of fissures that I would like to show you, along with the anatomical diagram on top and their MRI. Circumferential fissures is going to be like this. It's around the circumference. Okay. Then the MRI, over here you can see the arrow. Then there's going to be radial fissures right above me, which is again denoted by the arrow. It's going radiating in a particular direction, rather than it's very pointy, rather than circumferential being very bulgy. Okay. Then you have got peripheral rim fissure, which is focused entirely on the periphery of it. Now, here is the degenerative stages of the disc. Okay. So what and how it leads in particular to different levels. So you got normal, you got degenerative, you got bulging, you got herniated, and then you got thinning. And this is what the distances of it reduces to. Now, we will be talking about the mechanism. Nuclear migration is once when there's tear happening. What can occur in this particular is that they can force the material outside and to a path of least resistance. Resistance will be via the layers. The lowest number of layers, which means less resistance. Less resistance, bulging will occur in that particular direction. Common location for annulus fibrosis, thinner posteriorly. So posterior longitudinal ligament is narrower and centrally in lumbar spine, supporting less support laterally. Next, for new medical students or planning to get into neurology or neurosurgery, some terms for them. Three in particular: protrusion, extrusion, and sequestration. Protrusion is when the disc material extends beyond the vertebral body margins, but the annulus fibrosis largely containing the outer fibers contain the nucleus. Extrusion is annulus fibrosis is ruptured and nuclear material escapes the disc space, but remains continuous with the parent disc. Sequestration. Extruded material loses all continuity with the parent disc and becomes free fragment within the spinal canal. This fragment can migrate superiorly or inferiorly, emphasizing the surgical relevance over here. Okay, the surgical relevance, the point I've written is going to be something I would like to say. What happens is when disc herniation occurs, we have to have certain surgical measures to be taken in place. First off is going to be minimally invasive therapeutical procedures in the treatment of discus hernia. How will we do that? There are various methods to treat them, most laparoscopically. Usually in the history of time, it was done open surgery way. But nowadays, with the advancement in technologies, we can actually conclude that laparoscopic is the most safest way and there can be easy recovery. Recovery time is usually between 1 to 2 days for patients. And after that, regular follow-ups is required just for monitoring the particular disc which was operated on. Next, I'll be talking to you about pathophysiology. The main heading of this is actually radicular symptomatology and how indirect pigment and neural structure can affect it. So, what is radicular symptomatology? Direct mechanical compression. Direct mechanical compression is going to be how the direct force occurs on the disc and how it gets compressed. This leads to deformation, critically causing weakness, and that weakness can then lead to certain syndromes and pathies, radiculopathy or Kodak venous syndrome. Crucial points to remember is that nucleus pulposus is chemically very irritating. So when the extrusion occurs of nucleus pulposus, it releases inflammatory mediators into the body. Specific examples to be mentioned: TNF alpha, interleukin 6, nitric oxide, and phospholipase A2. These cause a profound inflammatory reaction around the nerve root, leading to severe pain, dysfunction, and significant mechanical compression. This explains the efficacy of epidural steroid injections. Okay, that's where it helps, the steroid injections. Vascular compromise is what is very critically seen in clinical pictures that you and I, as a consultant, as a doctor, might experience at least once in their whole career. Compression can compromise the microvasculature supplying the nerve root, which is vasa nervorum. This leads to nerve root ischemia, edema, and further impairing nerve function. Then you have got neural damage, which is chronic decompression occurring, and inflammation, which can lead to demyelination. There can also be certain aspects of axonal injury, which is persistent with neurological deficits. Okay. I hope it is clear and very evident that my voice is okay. Now, again, another diagram. This is an animated version, but this diagram in particular is going to be different than what we have been seeing. To your right, you can see a normal disc, but I would like you to focus on one thing, which is the nerve roots. You can see the nerve roots which are going. These are normal, but to the left, you can see herniated disc, which is compressing the nerve root. And that kind of protrusion you see over here is what is causing the compression. Now, clinical correlations, as you can see over here, is going to be about radiculopathy, one thing, myelopathy, second, and choroid venous syndrome. I'd like you to take some time into first looking at the diagrams, then we'll talk about what it is. Now, this is our radiculopathy. Discus hernia in usual terms happens in accordance to mostly the lumbar side of the vertebra. Then thorax, then cervix. This is how the commonness chronology goes. So as you can see over here, the entire feet or the leg of a person is present, and the certain aspects of it is which has got the nerves which can get compressed. So L2, L3, or L3 to L4, or L4 to L5. Most common is going to be L4, L5, and L3, L4. That was about radiculopathy. Then we'll talk about myelopathy. Cervical thoracic spinal cord decompression. Then there's going to be gait disturbance, spasticity, hyperreflexia, and clumsiness. Over here, you can see a radiodiagnosis and damage in blood spinal cord barrier and how it leads to gait paralysis. And on the top, very top, if I like to take a close look on how the degeneration occurs and what the arrow you can see, arrow is in which direction it's actually protruding out. Okay. And choroid venous syndrome, which is specifically lumbar. It's a neurosurgical emergency characterized by bowel bladder dysfunction, subtle anesthesia, and bilateral lower extremity weakness. This is what choroid venous syndrome looks like. Okay. And you can see the areas affected in this particular one. How in this particular area, which is the part where you can see the CES treatment is happening and how it is going to be treated. CES is the abbreviation for choroid venous syndrome. So herniated disc material is removed to decompress the nerve. And on top, you can see how it actually affects the bladder function and why it has been removed. Conclusion, I would like to say one thing is that the comprehensive understanding of anatomical structure in terms is going to be dynamic and physiological process of degeneration is going to happen. But in order to treat them in time, we have to make sure that timely diagnosis is done and how we can actually work towards curing the patient for a longer term rather than curing the disease on a shorter term. Future directions, we have to choose one or two relevant to neurosurgery, which is going research in biological approaches, advancement in minimally invasive surgical techniques, and further elucidation of the inflammatory cascade offers. Potential for novel pharmacological interventions can also be there, which would reduce the surgical interventions. Thank you so much. It's been Dr. Yash, and it's a pleasure presenting.
Okay, very good. Thank you very much, Yash, for taking the time to put it together. I know this is a relatively new platform for a lot of students, but I think they'll get less shy and start joining webcasts like this. But it certainly is good for students like you and Rohan to have your face seen and known in the neurosurgery community. You both are just starting on your career, and basically it's building your reputation easily, and it helps. Now you have the tools so that neurosurgery programs and school and places you're going to be applying for jobs, they have a way to see you in action. And when you send the video resume that you're going to accumulate, because it's going to be good for your application for them to see you active in the community, teaching. As a neurosurgeon, you teach your whole life. They don't stop. You know, it's not a question. I think more than other specialties, I think neurosurgeons do more continuing medical education because they realize it's a lifelong process. And with the day of digital, you have access to minds all over the world. We haven't even tapped the potential for teaching, and it's going to get better, and we're going to get better. We're going to get more students interacting. In this particular time slot, it's going to be India Neuromed students. This is going to be a time slot, and we're going to work to improve it. We'll maybe have a couple of webcasts. I'm meeting with some friends of Rohan, and they want to televise. So I want to make it so that when you guys come, you see a couple of different things, not just presentation, which is fine. You can even have a couple of presentations. If students like that, we'll do that. And hopefully we'll communicate between Atta, who's essentially going to direct what you guys suggest. I hope you guys will suggest some shows, and tomorrow I'll meet with Rohan's friends, and we'll try to establish a curriculum that's going to grow and that's going to attract more medical students that want to be neurosurgeons. Neurosurgeons are funny. Most of the ones that I've met, they know early what they want to do. There's not many I've run into that said, well, I was considering neurology and considering this. No, most of them want neurosurgery or nothing at all. Now, I don't know how you guys are. What was it like for you, Yash? Were you from the beginning neurosurgery, or did you kind of develop it in medical school?
Oh, it's actually been from the beginning, always. I
Yeah.
always aspired to be a neurosurgeon. I always aspired to be, because I personally am very passionate about how the brain actually works in its own way. It's the beauty of nature of how we actually have a mind to work on a mind. And I really want to work towards achieving the best goals in life in the field of neurosurgery.
Well, how about you, Rohan? Did you know from the beginning that you wanted to be a neurosurgeon, or that come later?
Yeah, yeah, it was with the passion of addiction medicine and along with some other field of interest in neuroscience. So yeah, neurosurgery
Well,
was the field of choice
going back to
due to the
Yash,
intervention aspect.
going back to Yas's presentation, in medical school, we used to scrub in on disc surgery, and I had no idea what I was looking at in the field. And sometimes it's difficult to see when you're a student with the retractors. You don't want to stick your head in the field. And the neurosurgeon used to say, "Oh, you see the disc there?" And of course, being a shy student, I'd say, "Yeah, I see it," but I didn't see a thing. And having a presentation like this would have helped me understand what he was talking about and what he was trying to show me. If I saw this video before going to the OR, I would have been a lot better prepared. And because you guys, as any doctor, is going to see low back pain for the rest of his career. General practitioner, neurologist, neurosurgeon, other doctors, family doctors, they're all going to see back pain. It's the most common complaint that patients will have. And even as a neurosurgeon, it's going to be one of the top complaints that your patients have, low back pain. And you have to adjust to what Yas presented to. You have to get to know the anatomy, what is wrong, what's the pathology, and get to discuss it with neurosurgeons and other students, which I feel that Zoom today is not as interactive as it should be. It'll get better and better because I've been in Zooms where it's very interactive. You got some active, mostly attendings speak, mostly neurosurgeons. Students don't say too much. Usually, they're always welcome to, but usually they kind of sit back and wait for the neurosurgeon to talk. But if you get a couple of neurosurgeons talking, it's gold just to listen to these guys. I'm sure you guys love to listen in the hospital. And where I trained, we didn't get much attention at all from the neurosurgeons. It was so crowded, they were so busy, they just didn't have time. And I think neurosurgery is going to open up a little bit with the more online education that you get. And you'll be able to understand more. You'll be able to ask more pointed questions to the neurosurgeon, and it'll improve your educational experience that I feel. So, does anybody have any questions or comments on Yas's presentation? Okay, well, Yas, I like the way your picture, your photo was on the screen. That was good. Can you go to your screen right now and put your presentation on?
Just a second.
How'd you do that? How'd you do that with the putting your head in the presentation?
So actually, there's this new feature called layouts when you screen share, and in that you can have the access of like putting your own like face and body as a particular like a front end of the screen, and then in the background it will be whatever you wish to share.
Oh,
And
okay. Can you do it now? Could you do it now?
of course, this is it.
Okay, so you put yourself on that platform and then you add your background screen.
Yes, yes. So what you're seeing at my background is what I'm controlling with my hands over here is the presentation.
That's excellent because you were pointing to things, and that's excellent.
Yes, yes. I actually intend to do it that way, that I wanted to get very involved in what I'm teaching. That's why I was going like this and like this.
Well, can you stick around for a minute? I'd like to learn how to do that. I've seen it before occasionally, but I get caught up and don't stop the neurosurgeon and say, "Oh, can you show me?" Yeah, after the webcast, we'll do that. So.
Yes, sure.
Okay, very good. We'll end this webcast and appreciate you doing it. And thanks for coming, Rohan and others. We'll be
Thank-
meeting again next Saturday, and we'll try to have more shows for you guys, more presentation, and we'll work on that. So I'm going to end now. Stay here, guys. I'm just going to stop recording. Okay, now.